Thank you, Ben, and good evening, ladies and gentlemen. Thank you very much for your attendance, not just to those of you who are here at the Royal Melbourne Hospital, but to all of our guests watching us online. I hope you find the session informative and useful. As a trauma surgeon at the Royal Melbourne Hospital, today I'm going to give you an overview of trauma in the elderly patient population, and hopefully through this talk I'm able to highlight some of the issues that we face or challenges that we face on a day-to-day basis in managing this particular age group. I'm hoping that this talk will then set the scene for the remaining presentations that are to be given by our wonderful speakers this evening. So we all know that the size of the world's population is increasing, but we need to be aware that it's also aging. According to the World Health Organization, the number of people aged 60 years and over is going to increase from 900 million to 2 billion by 2050. Now, this will have a significant impact on our healthcare resources, not just for primary care, but long-term care as well. The World Health Organization is strongly advising health services around the world to firstly recognize the need, and secondly to develop resources that are appropriate, or a workforce that's appropriately resourced and trained to recognize the needs of the elderly. They talk about older person-centered care that needs to be integrated. With respect to Australia, our population is also aging. According to the Australian Bureau of Statistics, the proportion of people aged 65 years and over is also going to nearly double. For us, this has been attributed to the sustained low fertility rates, but also the increased life expectancy of our population because of improved lifestyle factors and our wonderful healthcare system. Now, some of you may have heard of the term silver tsunami. Essentially, it's being used increasingly in the literature to describe the shift in the demographic shift in the population. Now, whichever natural disaster phenomenon you wish to use, hurricane, cyclone, earthquake, to describe this aging population, we all need to recognize that we will be having an increasing number of older people around who will hopefully be more active and will be living their lives to the fullest. But at the same time, through their sheer presence for much longer times, they're going to be involved in more trauma. So they will be having car accidents. That's actually a real accident. This guy rolled his car in California, and his wife requested for her phone so she could take a selfie while she was being rescued. But they will be falling off their bikes. Unfortunately, they will be run over by cars, making trauma no longer the disease that's been previously perceived as solely or predominantly for the younger adults. Now, the other things that the older people tend to do, they have a fascination with heights. So they're going up ladders to pick fruit. They love to prune their trees and their plants. And for some reason, when it's wet, slippery, rainy and cold, they want to get up on ladders, and of course, they fall. Unfortunately, from the trauma surgeon's perspective, it's not the juicy fall from height falls with lots of injuries. They fall from stairs, they fall from standing height, they fall from standing height. Now, just looking at some data from the Victorian trauma registry, as you can see here, the largest increase in the rate of hospitalization for major trauma consistently, when you look at the last 5 years, it has been in the oldest age group, so age greater than 84, whereas for the remaining age groups, it has remained steady. When we look at the most common mechanism of injury for hospitalization for major trauma, it is falls, which is low falls in those who are aged greater than 64, and it's not surprising then to see that the most common in-hospital, the most common cause for in-hospital deaths in major trauma then is for low falls. So to summarize that data, old people fall from standing height, they sustain injuries, they get admitted, and unfortunately, many don't survive. Now, what's happening at the Royal Melbourne Hospital? Our trauma numbers over the years are continuing to increase. In 2018, we had 4,672 total trauma admissions to the hospital. Of this, 1,228 in red, you can see, is for elderly patients aged greater than 64. And of that, 333 qualified as a major trauma. So a third of our trauma admissions are older patients. A third of our major trauma are older patients. The most common mechanism of injury is falls in the older groups. As you can see, 59% in those age greater than 64, followed by motor vehicle crashes and then pedestrians, as opposed to the younger patients who are involved in motor vehicle crashes and then falls. In the younger population, the falls are higher falls as opposed to those who are older. When we look at where these patients are being managed, the majority of the patients are being admitted under the trauma unit. The trauma unit is a consultant-led surgical service. But you can also see there that we have orthopedics and neurosurgery who also admit patients, as well as emergency and short-stay unit and the medical units. For both the younger adults, but 75% of the elderly trauma are being managed by a surgical team. Here we have percentage of a proportion of patients who are being admitted to ICU. All of this data is for major trauma. So about a third of the elderly major trauma are being admitted to the intensive care unit. Whilst having a lower injury severity score, they have a much higher death rate when they're admitted to ICU. When we look at our overall trauma deaths by age, the older patients have a much higher rate per year despite a lower injury severity score. We've started to collect data for anticoagulation therapy in our major trauma patients. The blue box is summarizing the data for all of our trauma, the major trauma. So 44% of the older patients are on some form of anticoagulation therapy. When we look at falls specifically, 48% are anticoagulated, and of those, 39% are again in patients who are having low falls. With length of stay in hospital, I think the obvious significance is in the minor injured patients. So all the patients which don't qualify as a major trauma compared to the younger ones end up being in hospital much longer, so on average 3 days compared to 0.7 days in those who sustain major trauma. And when we look at our discharge destinations, so if you just look at the orange bar, which is summarizing the results for the older major trauma patients, 62% are discharged to some form of rehab, and unfortunately they have twice as much as a death rate, so 14 versus 7% in the younger patients. So to summarize this data, the older patients have a higher mortality, longer ICU stays, longer hospital stays, and are more commonly discharged to nursing home. This is no doubt related to their age-related physiological changes, which are then exacerbated by their injuries and also the treatment of their injuries, and they have high rates of pre-existing comorbidities and complications. So at Royal Melbourne Hospital, we're very good in dealing with patients who are injured. We resuscitate them well. We are very good at identifying their injuries and putting them back together. This is a real-life case that I was involved with 2 years ago. A 75-year-old man who was cleaning his gutters on a rainy day. He fell off the ladder, presented as a trauma call, hypotensive, hypoxic. He had a high injury severity score. Just for the sake of time, I'm going to let you know that he had multiple interventions. So a 75-year-old had 2 angioembolizations, 3 laparotomies, was in ICU for 13 days, 22 days in hospital. He was discharged to rehab. I reviewed him personally in clinic, at home at 6 months, independent, walking 5 kilometers a day. I would like to say, or I wish all of my elderly patients were like this, but that's supposed to be me, but, so I've deliberately left my hair out because Ben says it's my only it's a defining feature, despite how hot it is, but just bear with me. So the question is, what about all the other patients that don't come with the bells and whistles like the patient that I described? When we look at our data, almost 900 of our admissions are elderly trauma that don't meet the major trauma criteria, right? One of the deficiencies of our databases, the registries, is that we're so focused on major trauma. All of our outcomes and assessments are for major trauma patients. What about the minor trauma? This is a snapshot of the trauma inpatients at the hospital. I've blocked out the patient identifying information. This is half the page because I couldn't fit the rest. But just on this page, a quarter of the patients are aged, the ones that I've marked, over 64 years who've sustained falls. Now, this is what happens on my ward round. I have the diligent registrar who says to me, Mr. XY is 86 years old, who's presented from a low-level care nursing home, he's fallen from standing heights. He's got a small subarachnoid hemorrhage, some rib fractures on the right side, and possibly an old crush fracture of his L1. And then we get his past history. So AF, congestive cardiac failure, TIAs, type 2 diabetes, I can't even say them as the surgeon, I'm having a panic attack right now, but chronic renal failure, mild dementia, Parkinson's, and a recent decline in function. And then we go through the meds, and I've got this bubble expanding because I'm truly getting palpitations now because the patient's anticoagulated, they've got diabetic meds, they've got Parkinson's meds, and then then comes the bit that really is causing anxiety, because I hear this patient's either confused or delirious. As surgeons, we are terrible in recognizing delirium, let alone managing it. Now, when you put that in the trauma scene, where you've got someone who has previous cognitive impairment and the sustained head trauma, what are you supposed to do with them? I mean, what does confusion or delirium mean for these patients, right? So then we move on to then having to organize their goals of care, getting the other disciplines involved to get definitive management plans, the allied health review, and making decisions about discharge planning. And all along, I'm thinking, as a surgeon, there's nothing for me to do for this patient, right? So that's going through my mind. And so the list continues, and I hear NOACs and DOACs. I mean, where did DOACs come from? I just got my head around NOACs. And so then it's like Chad Vascore and the registrars are really pleased with themselves because they see the look of horror on my face. And I get the sinking feeling, and I start asking for help because I need the Jerry's registrar to come and help, not just me, but the poor patients as well. So thank you very much.